Hello, everyone. Corey Wisner here. So I have the pleasure of introducing our next session. So we have Pooja Chitre, and it is entitled Exploring Data Work for Obstetric Quality Improvement in Hospitals.
Hello all. Thank you so much for taking time out to listen to this presentation. I am Pooja Chitre. I am a PhD student at Arizona State University, and I will be talking about this work in progress about understanding data work for cesarean section rate use in hospitals for quality improvement. This is a cross-comparative case study between the US and in India. I'm currently collecting data about hospitals in India, and hence I do not have anything to present at the moment. Today's discussion is based on the findings from the United States. After this presentation, you will be able to define what data work is, apply data work to understand the use of cesarean section rate for quality improvement, and understand how data work can also be used to understand numerical indicators other than maternal health outcomes. Data work has been defined as human activities of creating, collecting, managing, curating, analyzing, interpreting, and communicating data to make it meaningful for health. It has been chiefly used to understand who does the labor. Is it the nurses, the patients, the doctors, or any other administrative staff? It is used to understand what kind of work is performed and by whom. Is it translation work? Is it just plain reporting? It is also very crucial to understand the issues of data, like poor data quality, poor reporting workflows, or missing data. And the most important aspect that data work helps us to understand is the effect of the data that is being generated on the workers and the organizations themselves. And this is one part that we will focus on in my presentation today. Let's look at the case. How can data work help us to understand how cesarean section rates are used in hospitals? Cesarean section rates are one of the most important indicators which indicate the quality of services provided by hospitals. There are different benchmarks that exist. The most popular one is the 10 to 15% recommended rate by World Health Organization. This means that any hospital or any nation which has its cesarean section rate between 10 to 15% automatically translates into having a certain level or a certain quality, good quality of health. However, cesarean section rates are rapidly changing in the last 20 years or have changed in the last 20 years. They've either been well over 15% or in certain vulnerable populations, they've remained as even lower than 10%. That means that there is either overutilization or underutilization of this particular life-saving procedure. So in such circumstances, how do hospitals make cesarean section rate actionable for quality improvement, especially if the cesarean section rates are high? How do they ensure that they can be made relevant to quality improvement programs? I propose that by studying the data work for generating cesarean section, that is why it is in action or it is being generated, and the second type of data work, that is why the data work required to align an organization to this benchmark. It will reveal the gap between the policy and actual implementation. So let me take you on the preliminary findings that we have from the US hospitals. So there has been certain data work that has been conducted, create a cesarean section, special cesarean section rate to show that there has been clear-cut improvement in quality. Secondly, this cesarean section rate has been equated to the performance of a physician, as in the cesarean section rate is tied to an individual physician. It redefines how quality is understood. It is often as, quality can be calculated based on a physician or a hospital. If they achieve a certain benchmark, that means that they are good physicians or good hospitals. This has resulted into another kind of data work, that is of constant surveillance. There are different set of people who survey these physicians and the hospitals continuously to see if if the benchmark has been met or not. Moreover, there are nurses and midwives and other kinds of staff who have to record other kinds of scores or that elaborate the cesarean section metric further and breaks down it into every single step. So there is increased datafication at each step. This has made there is a decoupling between why quality exists and what it has become. It has become more of a show, is what we have realized. And it is just to show that there are improvement or there is improvement in the quality programs. Secondly, there is constant state of anticipation in the nurses and the doctors specifically to see if they will be audited now or later. The tensions, because of the oversight mechanisms and the surveillance mechanism, there has been tension between nurses and physicians. So the main policy question here is quality is achieved, but at what cost? This presentation is not a critique on data-driven QI, but it is to understand how numbers affect the workers and organization in the pursuit of achieving these goals. Thank you. If you have any questions or feedback, please feel free to email.